Okay, so today I'm going to talk to you guys about migraine a little bit and a new program that we're going to be starting down in the chiropractic department, but really it's a new department that Dr. Denny and I are starting, the functional neurology department. So for those of you that don't know about functional neurology, I'm going to talk a little bit about that today, but then kind of focus it on migraine because migraine is one of those things that many people suffer from, and the options out there for treatment are just kind of not good all around. It's very hit or miss. Myself, I have suffered from migraines my entire life, and so I've kind of been through different modes of treatment, and this is really the kind of care that really kind of transformed my life for me. So just a little bit of background about me. I am a chiropractor by trade, but then I also did postdoctoral studies in clinical neuroscience. This is what functional neurology is. And I am a diplomate through the American Chiropractic Neurology Board. And so what does that really mean? It just means that I took the time to study a little bit deeper into the nervous system and neuroanatomy and learned how to use the principles of neuroanatomy to my advantage as far as treatment goes. So we'll talk about that in a second. Let me just get to where we want to go. So when talking about migraines, there's really a bunch of different types of migraines we have to consider, and this is huge when it comes to, number one, your diagnosis, but two, how you're going to treat them, because no migraine is the same, and no person that experiences migraines is the same. And often what I find too, myself included, through just what I've personally been through, that people can kind of suffer from multiple different types of migraine. They may have chronic migraines, but then they might have headaches on top of it. They might get clusters, but then they might get these drawn out migraines. So it's kind of important to understand what type of migraine you're working from or working with, and where that's really starting in the brain. What's the real culprit behind it? So there's all these different types of migraines. I'm not going to go into them in detail because I want to talk more about the program that we're going to be doing. So our program kind of really hits on four main factors of migraine. We have to treat all four factors of migraine in order to find people the results they want. And that's kind of where there's a misstep right now in migraine treatment. We're treating one system, maybe two systems, but not all four. And so we need to address all four because some person may need all four. They may not, but they're all important. So hormonal is the big first category. And so this is going to be really important to females in particular. Currently for migraines, some patients are using birth control, hormone replacement therapy. Again, this might lead to some other health issues down the road. But a lot of females that get migraines report that they have an increase up around their cycle. And we've kind of been able to correlate these stress and estrogen responses. And so a lot of these migraine patients, when they have this increased stress response, which they're going to have because they're in pain quite a bit, pain and stress are very linked together, which I'll talk about in a second. But when we've got this extra stress that we've got going on, then we're going to see changes in our hormone, and we're going to see where instead of making estrogen, we're going to be making these stress hormones that we need in order to handle the stress that we're going through. So we see a drop in these estrogen levels, especially in women. And so we may need to run a hormone panel on a woman and see, okay, are their estrogen levels super low? Are their cortisol levels super high? And let's supplement to kind of fix this for that person. And also let's teach them how to manage stress. Stress management is going to be huge for migraine patients. As I said before, stress and pain, they're very intimately linked together. And so in the body, if you think about our body as sort of a computer system, we've got all these different wires inside, right, that travel different types of information. We've got some big, thick wires that travel information up to our brain super fast because they're nice and insulated. But then we have these smaller bare wires that don't have insulation around them, and the signal travels a lot slower. It can sometimes get lost. And so pain and stress kind of both travel up these uninsulated wires. And in the body, they pass near each other. We can get something, called a phaptic transmission, which is kind of a fancy term, but it's basically where if one's firing, it has the ability to cause the other one to fire because there's no insulation separating the two of them. So if I'm in pain, of course my stress is going to go up. Or if I'm stressed, sometimes we see this with patients when they're more stressed out, they're in more pain. And that's really the neurological reason behind that. The next big category that we need to address with patients is diet. We are what we eat. And we all know that a lot of our patients don't eat very well. It's kind of no mystery that in America especially, food has just become really crappy. And we've kind of gotten used to this now, I want things fast, I need things quick. And our food has kind of taken a cut because of that. Because we're, eating things that are going to be quicker, things that don't have as much nutritional quality to them. So we need to educate our patients on the importance of diet and really educate them on how diet can create inflammation in the body. There are certain types of food, and I know Dr. Denny and I, we've worked with some patients with diet using a blood type diet or an anti-inflammatory diet, but there are certain foods in our body that we eat, and it can vary from person to person, that is going to create an inflammatory response in our body. And when this happens over and over and over again, we get this inflamed gut, and that inflammation can spread beyond the gut. And there's tons of research coming out now about this link between the gut and the brain axis, and that the gut barrier is very similar to our blood-brain barrier. And when we see things like leaky gut because of this chronic inflammation in the gut, then we're going to see neurological symptoms down the line. So we need to address diet with these people too, getting them off of gluten, getting them off of dairy potentially. Sugar is huge as well, especially processed sugars. That's going to really, really spike your inflammatory response. And not to mention, sugar can be a neurotoxin in high excess. So we need to regulate that a little bit for these people. And it may just be a simple anti-inflammatory diet for them. We may have to do some more intense food sensitivity testings, but again, it varies person to person. Okay, so the next factor, musculoskeletal structure. Like I said, I'm a chiropractor by trade, so obviously I'm going to be interested in what their spine looks like, what their upper cervical spine looks like, their neck, because sometimes we can have an issue going on with the upper neck creating headaches or some muscle tone differences in the neck that need to be addressed. And they may need some type of body work, whether that be exercise, chiropractic massage, acupuncture. Again, it's trying to find what's going to be the right type of body work for that patient, because not everybody's going to respond to the right type of care. I can adjust one person and it might be great for them, but for the next person I see, it may not work for them. So we have to kind of figure out what's going to be the type of body work that gets the structural response we want with the least amount of inflammation. Because again, the name of the game here is bringing all that inflammation down. Yeah, so that's all I'll say about musculoskeletal. So the last component, neurological, and this is the big one, and this is really what functional neurology is focusing on mainly. So we kind of have two aspects to consider. One, are they genetically predisposed to headaches? Especially in women, if you look at women, you can see this correlation of migraines passing down from mother to daughter, grandmother to mother to daughter, and it sort of can run in families. So does this person already have an altered brain state that makes them more susceptible to migraines? So we need to do a history, a very good history. And knowing that about them, that kind of leads us to the point, do we know that their neurons are more likely to fatigue and fail quickly? Can they only handle so much stimulation at a time before they're just cashed out? And through our exam, we have to figure out which parts of the brain are not as healthy as the others, which ones don't have as much output as some of the others. So and like I said, this is really done through our exam. When I do a neurological exam on somebody, it's much more in depth than the one I'm doing chiropractically. I'm doing much more orthopedic exams with my chiropractic patients, but with functional neurology, we're looking at how their eyes move, how they can focus on targets, what their balance is like, what their movement is like. If I move their head one direction, are they going to feel dizzy? If I get their eyes to come up this way, is that going to improve their posture? Things like that. So we're kind of looking for all these subtleties in the exam, things that, you know, traditionally, some of these subtleties we wouldn't necessarily pay attention to. We might just write them off. Because in medicine, a lot of times we're looking for a hard lesion. We're looking for these black and white signs. Okay, this is what you have. This is your diagnosis. But sometimes for these migraine patients, we know they have migraine, but we don't know what the cause is. And so that's where these subtleties come from. We're looking for these parts of the brain that aren't working so well. For instance, if I'm having a person just track their eyes in one direction, that's going to connect to the parietal lobe on the same side of the direction we're going to. If I'm having them go from target to target, that's going to help me localize their frontal lobe. So again, those are all the things we're looking at. And then the other thing to consider, did they get this through an injury? We do a lot of auto here, and we see a lot of headaches after a collision, an accident, a whiplash injury, or fall. So is that what caused it? Was it a concussion? Do we need to address some concussion symptoms as well? So one of my good buddies who specializes in functional neurology as well, he's kind of one of the lead guys doing migraine in the country right now. And he kind of came up with this theory that I think is great because I think it explains migraine really, really well. So if you think about everybody's brain has a bucket, okay? We all have a bucket in our brain, and everybody's is a different size. Mine's one size, yours is another, yours is another. And this bucket, depending on how big it is going to allow us to adapt to stress. So the bigger the bucket, the better we are at adapting to all the stress that's thrown at us in a day. Nutritional stress, any musculoskeletal, structural stress, hormonal stress, neurological stress, so pain. And the bigger this bucket, like I said, the better you are at adapting to that stress throughout the day. But most migraineurs, this bucket's really small, so any little bit of stress thrown at them over the day, they're just going to tumble right into a migraine. I know for me, when I was really experiencing my migraines, all it took was, a bad day for me to feel like crap. Currently, sometimes the weather still is enough to make me feel like crap. Lack of sleep was something that would make me feel like crap. So all these little stressors that for most people, they can handle that. They can still get through their day. For me, for other migraineurs, it's enough to just send you into a downward spiral where you're now in bed for the next day. So all of this care is built on the principle of trying to make this bucket bigger for that person. We're trying to make your bucket as big as we can. And again, this is done through all the 4 components that we just talked about and the brain-based rehab, which is the most important part of it. So kind of to sum up, migraine is due to this altered brain state, and it's a weakness in certain areas of the brain. A lot of my migraine patients, I tend to see where it's their brainstem that we need to work on, their brainstem health, because that's where our autonomic system originates from. Our autonomic system is the blood pressure, heart rate, our breathing, our digestion, all the things we don't have to think about doing. And that vagus nerve, and so docs know what I'm talking about with the vagus nerve, but this vagus nerve is what governs that whole stress response system. So we need to really work on that brainstem. That's usually my focus with most migraine patients. Like I said, it differs from person to person, especially the mechanism of injury. And then it's usually at least one of the other 3 categories, but it might be all 4, so that's why we have to address them all and find out which categories we need to work on. It's a very, very detailed exam, very detailed history. So our program starts with the exam, any lab testing, any imaging that we might have. Usually a lot of these patients, by the time they're finding a functional neurologist, they've seen everybody there is. They've got a lot of testing already, so it makes my job a little easier sometimes. I don't have to go do that. And typically with patients, I start them off twice a week for 8 weeks. Again, it can vary from person to person depending on their condition. And then we do a reevaluation. But the treatment includes this brain-based rehab, which is tailored to each person specifically, and that's really done through the exam. So, for instance, when I'm looking at their eyes, if I notice that, okay, they can't track really well this direction, and then they can't hit a target this well that direction, then we're going to work on those eye exercises. That's going to become part of our therapy. We work a lot on gaze stability. And making sure that their eyes can hold a target and stay on a target. Migraine as well, like I said, it's really connected to the brainstem, but sometimes they've got a vestibular component, a balance component, where they can't make up for the time where their head turns and their brain catches up to where their head's at in space. Again, nutritional counseling, supplementation if we need it, massage, chiropractic, again, if we need it, and lots of homework. This kind of care has to have repetition because our body is plastic, our nervous system is plastic. The more that we train it and teach it, the quicker it learns. So it's important for these patients to not only do the work when they come into the office, but do the work that they need to at home. And that's really where you see the difference in patients that get better quickly and the ones that take longer to get better. And you can tell as a doc. I mean, when they come in and do their eye exercises, you're going to know if they're doing them at home or not, because the brain is really quick. It learns really fast, and you can see these changes very, very quickly.